I believe we have everybody on, and I'm not going to be moderating, but on behalf of the health department, I do want to welcome everybody and appreciate so much our panelists giving their time for us to do a good COVID update, especially targeted towards healthcare workers. And we want to make sure everybody understands where we are in the course of the pandemic, and then I'll make sure that we're able to review the importance of the safety and efficacy of the vaccines that we have and monoclonal antibody therapies that we have, and then hopefully be able to take some questions. I know there are still those who in the healthcare world that are looking at what to do with vaccination, and have been challenged with possible federal mandates, none of which are on the table for healthcare right now. But the purpose of today's town hall was just to provide hopefully trusted, reliable information for those who are still working to make that important decision regarding vaccination, or even boosting, or vaccinating children, or whatever you may be facing. So we're very happy to be with you today. I'm Dr. Dan Edney. I'm the Chief Medical Officer for the Mississippi State Department of Health. And I will just start us off by giving a quick update of where we are. I know everybody wants the epidemic to be over, but unfortunately it is not. We are seeing our numbers trend upwards, which is no surprise following Thanksgiving. We're reporting out between 400 and 450 new cases per day. Last week, 7-day average was about 442 new cases per day. If you go back to April, pre-Delta wave, we were down under 100 cases per day. And the bottom side of the Delta wave, we had gotten down to about 250 per day. So you can see we're just about double where we were a few weeks ago, and trending up. Our death rate is remaining stable at about 4 or 5 up to 7 new deaths per day. And you need to understand that these are Mississippians that mainly are unvaccinated between 50 and 64 years old, who are otherwise out working, enjoying life, and planning for Christmas that we have lost because of this infection. So it is important. We are still having significant consequences from COVID. The hospitals are starting to have increase in admissions. All the hospitals are short-staffed, and it's just important that we and the public do everything that we can to protect our healthcare system, our families, and each other through this. We definitely have to get through this winter season. Omicron is the big question, and we've had our second documented case in Mississippi. We've had a death in Great Britain, but we've had no reported deaths yet in the United States. Vaccinations appear to be holding well. We are seeing those with vaccinated immunity and natural immunity both getting it. So we still have more to learn. It appears to be, much more contagious than regular COVID, but not as, at present, does not appear to be as deadly as Delta variant is, but we still have more to learn on that. But your best protection against this variant is to be vaccinated. We have now a little over 1.4 million Mississippians fully vaccinated, and we have approaching 340,000 Mississippians who have received their booster dose. Boosters are now approved down to age 16, and if you are more than 6 months out from your last dose of your primary series, then you are eligible, and we highly recommend that you do get boosted. We now have primary vaccine available down to age 5, and we also have monoclonal antibody therapy, which is our main weapon for those who are infected with COVID, approved basically for all ages at the discretion. Children are now eligible at the discretion of their pediatrician or family medicine doctor. So that's just some general information for you to show that we still are in the thick of this. We do expect it to get worse before it gets better, but it is going to get better. But, we're losing too many people per day. I mean, thank goodness we're not losing hundreds of Mississippians a day as we were just a few weeks ago. But as a physician in Mississippi, losing 5 people who should not be dying to a largely preventable illness is just unacceptable. And it's happening day after day after day. If we had a sniper on the loose around the state shooting 5 Mississippians, we would do something about it. Well, we cannot become calloused to the number of deaths that we're just seeing every day. These are real people, real families, and we all need to get through this together. So let me turn the program over to Dr. Owens. Go ahead with women's health information for us.
Yeah, absolutely. So I'm Michelle Owens. I am a maternal fetal medicine subspecialist, an obstetrician gynecologist that works at the University of Mississippi Medical Center, and have the distinct pleasure of being able to talk to you a little bit about some of the important things to be mindful of as it pertains to women's health. This pandemic has affected everyone for sure, but specifically, I've been concerned about how misinformation has impacted women's health in particular, and has made those individuals who are already considered vulnerable among us even more vulnerable. And by that, I mean pregnant women and also their unborn children. Many of you have heard information about the increased risk of fetal loss that have been reported here in Mississippi. Since that time, the CDC has put out a publication that has confirmed that finding. So that is not just a Mississippi thing. We know that Delta is different, as Dr. Edney referred to earlier in his recap. And so we've seen Delta being an exceptionally aggressive form of the virus. Hopefully Omicron will not be that way, but we still just don't know. And we have to also prepare ourselves for whatever variants there are to come. And based on what we've seen thus far, I'm sure that there will probably be a new one to come at some point if it's not already out there. But specifically as it pertains to some of the misinformation, I just wanted to use this opportunity to reiterate again that the vaccine has been shown to be safe and effective, and is also recommended for pregnant women. Also, if you are a person who is planning pregnancy, there is no evidence to support that the virus causes infertility. And I think that's something that's really important because, as Dr. Edney said, this is one of the most important tools that we have available to protect ourselves against the virus. We know that when you are a person who is pregnant and you become infected with COVID, it increases your risk of ending up hospitalized. It increases your risk of having to be on a ventilator. It also increases your risk of death, substantially more than those people who are not infected. So if you have the opportunity to protect yourself prior to becoming pregnant, that is highly desirous. Additionally, it will give you a milder disease if you do become infected with the virus, which is another thing that's very important because, as I mentioned before, pregnant women are vulnerable. Their physiology is different. The way that their bodies work are different as they are building another human being inside of them. And so all of those things make vaccination and appropriate precautions especially important in those people, both within their reproductive years and beyond. I say that because I have a 94-year-old grandmother who's turning 95 in a couple of weeks. And so it's really, I think those are things that are really important. The concern that people have voiced about how they were concerned or hesitant about vaccinations, the way that that has impacted the overall health for pregnant women within our state and beyond. I don't think that we can underestimate that. And so as long as we now have way more data than we had 18 months ago about the safety and efficacy of the virus, as well as, of the vaccine, as well as how this virus behaves. And the thing that has been most impressive for us on the side of people who are taking care of pregnant women are these people who we are seeing who are not fitting the mold. They are not older people. They are not people who have pre-existing conditions. These are young, relatively healthy women who come in with bad pneumonia and who have to be on ventilators, and they require the strongest ventilators that we have in order just to keep them alive. There are plenty of people across our state, babies in NICUs are at homes with families who will grow up without knowing their mother as a result of losing them to the virus. I see patients in my practice where their whole family is vaccinated, but guess who's not? The pregnant mother. Why is that? And again, because they'll say, well, I'm afraid that it's gonna hurt my baby. You know what hurts your baby? COVID can hurt your baby. COVID can take you from your baby from you, or take you and your baby from your family. So I can't impress upon those of you who are taking care of pregnant women, if you are within reach of a pregnant woman, encourage them, share the truth about the deadly nature of this virus, especially as it pertains to pregnancy, and also about the safety and efficacy of the vaccine, so that they have an opportunity to make the best decisions for themselves and for their families and to be protected.
And thank you, Dr. Owens. Let's make a shift and let's get a report on what's going on at the hospital level. Then we'll come back and talk more about vaccines. But Mr. Higginbotham.
Thank you, Dr. Edney. I don't really know that I have a whole lot of information that you haven't already heard. We, in our organization, I think Dr. Camp Rogers just sent me the numbers. We're about 76% vaccinated. We would love to be 100%. So we struggle like everyone else trying to get over that hump. Dr. Owens, what you brought up, that is one of the issues that we run into. A lot of the childbearing and pregnant women are refusing to take them because they are concerned about harm to their children. I've also talked to a couple of others. There are some legitimate religious reasons, and I think the information about the fetal cell testing and that sort of thing, I'm not into all that research. I don't know all the research and how it's all tested. If there's information out there about how that's used, that may be helpful to help some people overcome some concerns. There are some legitimate, or in their view, legitimate concerns about the long-term impact of this. It was developed quickly, approved by the FDA, and they have some real significant concerns about, 2 years, 3 years out. I think one of the best lines I heard from one of my staff was, they don't want to be watching TV 5 years from now with the lawyer ad coming on and saying, did you take the COVID vaccine in 2020? If so, there's millions of dollars out there for you, that type of thing. So they're really concerned about the long term. If you're going to look at hospitals, and I think Ms. Russ will be able to probably back some of this up. What it's done is it's taken just it's created a real, I think, some tension in our workforce. Some people that are vaccinated feel like those that aren't vaccinated should be. Those that aren't vaccinated feel like, they're doing the right thing for them, and who are you to tell me what to do? So that's created some tension that we've not had before. When this vaccine mandate came in, what it also did with some of our workforce is they started looking at other options. Some of them they may not have even looked at before. I had a person leave to go drive for FedEx. He was a paramedic. I've had another one decide, they had 2 businesses they were running, decided, you know what, I don't have to have a vaccine to do that. I've had 4 people who are older decide they want to retire, which I find interesting because they're the ones that probably need the vaccine more so than others, but they decided to heck with it. I'm going to retire. I was talking with a business guy today. It's a larger business. They've got 45 nurses. The average pay for these nurses is $98,000. They've lost 4 since November 1, saying they're just leaving the field. So if you get into the rest of the healthcare, I can go into it. It's created staffing shortages. We're not unique in that. I think we've got 120 something positions open. I can't staff a floor. It's creating tremendous problems trying to transfer patients. We had a patient just last week. We called 23 hospitals in 4 states. Were unable to transfer the patient. I think it was Friday, we called one. I forget how many different hospitals and how many different states trying to move a patient. We finally found one in Gainesville, Florida. And we couldn't get an air ambulance there. So the only way we're going to have to send them 8 hours on a truck. Finally, we're able, about the time we were getting ready to move them all, New Orleans hospital called, said they can get a helicopter here. So, and this is because it's created such a shortage of manpower. Every hospital's looking at can't staff. Our ERs are short staffed. My floors are short staffed. Radiology, lab, you name it, it's all that way. And we're not unique. It's across the country. It's gonna, if another wave of COVID hits, in my opinion, we are going to have a significant death rate simply because we are going to be unable to provide the level of care that's necessary to take care of those patients. We won't have the staff in those areas, those particular types of illnesses that certain hospitals don't take care of. For example, we don't do nephrology. I'm not going to be able to move the patients, and I'm not going to have the tools to take care of them. So we are going to lose, in my opinion, a higher percentage of those with COVID than we did before, just because we're not gonna be able to move the patients. So that's pretty much all I gotta say.
How is your hospital looking now in terms of volume now compared to right before Thanksgiving? What are you seeing?
Our volumes are down, and that's primarily because I can't staff. We've got 3 main floors that take care of our patients. They're 38, 39 bed floors. One of them I can't staff. I've had 12 beds and got up to 18. That's the most I can staff on that particular floor. I just don't have staff to do anything else. Our nursing homes are another huge issue. We quit taking patients in the nursing home because I can't staff them, and I'm not going to be able to meet the minimum staffing requirements if I continue to accept patients. That then backs it up in the hospital where I can't get them out of the hospital. Can't get them out of the hospital. I can't move them out of the ER. So, then let's go a little further back. Your ambulances show up and they say, I need to unload a patient. I don't have a room to stick them in. So it's just a monumental problem right now. It all started with COVID. It's continuing with COVID, and in the aftermath of it, again, a good number of people have left the field, I think. There's some who are just saying there are other opportunities. And then the travel stuff has killed us. I can't match $186 an hour. I can't match that for an RN. $135 for a respiratory therapist. I can't pay that. I don't have it. If I do it 2 months, 3 months, we won't have a hospital at all. So you kind of have to say, I've got to reduce volume and do what I can afford.
And Dr. Camp Rogers, you work in the same hospital. Talk a bit about the importance of monoclonal antibody therapy. Y'all were great leaders in providing that valuable resource to your community, but share a little bit about your experience with it and the importance especially for those who make the healthcare decision not to be vaccinated.
Right. Thank you. My name is Teresa Camp Rogers. I'm a physician and chief quality officer at South Central. Mr. Higginbotham and I work together. So with monoclonals, we had first heard of monoclonals last October, I think is the first time it kind of came out, and we gave it as indicated. And then shortly, I guess right around the time that the Delta wave started, the evidence supporting its early and aggressive use had become more robust. So one of the things that we did at our hospital was we actually opened, I guess it was kind of like a pop-up clinic for monoclonals. And I think that it was similar clinics were opened around the state. What we did was we tried to remove every barrier possible that might prevent somebody from getting early monoclonals for COVID. And our goal was to have a 0 wait list so that when anybody called our clinic that they could get in within the next 24 or 48 hours. And if our wait list got a little bit longer than that, or if the time to treatment got a little bit longer than that, we would adjust up, right? We would change our workflow so that we could have see more patients. We ran that clinic for about 8 to 10 weeks. And then as the Delta cases started to decline, then we changed the model. What I saw during those 8 to 10 weeks was the benefit of early and aggressive treatment. What I saw was that if patients waited to come in, there was a higher risk around day 6 and after that they might be too sick to receive the treatment. And so while the guidelines do say you can give it up to day 10, and we did, if the patient met criteria, one of the things that I would like to share is just as soon as people get symptoms of COVID to get tested, and as soon as they get tested to get treated with monoclonals, because it can prevent hospitalization and by proxy prevent death. So that was our experience.
And Dr. Dobbs had shared with his leadership team that he calculated we averted about 2,500 hospitalizations through the worst of Delta. And you heard Mr. Higginbotham describe how bad it is now, and it certainly was so much worse in August and September. I can't imagine what would have happened to our hospitals had those 2,500 cases not been averted through monoclonals, plus
Right.
the deaths that would have come out.
Right.
They're about 80% effective for preventing. When we're talking about Delta and the other variants,
Yes.
that 80% effective preventing hospitalization and death.
Yes.
So very, very important. Thank y'all for what you were doing in Laurel. Saved hospitalizations and lives. Ms. Russell, Singing River, what have y'all been seeing?
We've been seeing very much what South Central's been seeing. Honestly, we've seen a little bit better success on monoclonal antibodies. As of this morning, we have given right at 5,000 doses of monoclonals and only had a 2% hospitalization rate from those patients that received monoclonals. I mean, that's incredible. We would have gone under without a doubt if all those patients needed hospitalization. And I want to tap in a little bit on what Mr. Higginbotham was saying earlier. We in our health system, and I think everybody knows we're a 3-hospital system on the Gulf Coast, we never really had seen contract and agency staff for nursing in our main campuses at all. Then starting in November, we started to see it chipped away at where we are really using quite a bit more of the contract and agency as he spoke of, and we've had to close beds. And that's something that the chief nursing officers have talked about quite a bit in the last couple of months. There's no doubt we have less staff beds in the state of Mississippi than we've ever had before. The State Department of Health has reported number of available ICU beds, med-surg beds, how many patients have been admitted with COVID in the last year, and the numbers of reported staff beds continue to drop down. And it's not that COVID's hitting our workforce like it did before. This time last year, we had quite a few staff who were out, either had been infected or were potentially infected. What we're seeing now, though, are primarily nurses, registered nurses and respiratory therapists who are taking travel positions outside of the state. So that's really what's driving the shortage of available staff beds right now. I think everybody's aware of the fact the nursing crisis is truly a crisis, especially in this state. What does that mean? That means there's more pressure on us to make sure that our community is vaccinated. And as of this morning, we had given right at 70,000 vaccines through Singing River. That's quite a bit. We would love it to be more. We'd love it to be triple that. And among our own healthcare workers, the people working in our facility, honestly, the acceptance level was disappointingly low. I won't lie, especially among nurses. And for reasons that Dr. Owen cited, may want to get pregnant, et cetera, et cetera. A lot of concerns about fertility. And we know nursing primarily is female based. But with the mandate that came out November the 4th that was going to require all healthcare agencies receiving CMS funds to be vaccinated. We did see our rate go up about 4%. We were meeting one-on-one with employees, talking to them about their concerns and issues. And some of them would just absolutely blow you away. I mean, I was born and raised in the state, and I had people who would tell me their spouse would divorce them if they took the vaccine. And you're just like, your spouse would divorce you if you took the vaccine. And a lot of those were political reasons, just did not really believe that vaccination with this particular type of vaccine, whether it was the J&J or the Pfizer and Moderna, was appropriate. And like I said, you start listening to them and they have tears in their eyes and they truly are fearful and concerned. And some of the people with one-to-one, they did agree, they thought that it was risk versus benefit. It'd be better for them to get vaccinated. But I can tell you, I don't have the exact number, but we have had quite a few people ask for exemptions for religious reasons and medical reasons as well, that we're working through that process. And with Omicron hitting the horizon, we had a little bit more of a rush for people to get those vaccines that maybe had been sitting on the fence. But primarily, we're worried about the shortage of available staff beds, making sure that we don't have a surge like we did with Delta. One of our hospitals had over 50% of its patients with people who were infected with Delta, and they were younger, healthier individuals. It wasn't your grandma's COVID like we saw this time last year. It really was far and away a lot of younger people. Delta, in addition to the mortality rate, what we saw here at Singing River, we do have the blessing of having intensivists on all 3 of our campuses. We had people who could not be maintained without BiPAP, CPAP, and a lot of ventilatory support. That was something we did not see the first 2 waves. Sometimes high flow O2 was sufficient. And we did see a lot of people who were having miscarriages. And we saw several mothers who had to have emergency C-sections who had been impacted with COVID. And, within a day of getting it, they were so sick, they had to have emergency sections. So pretty much what the rest of the panel has seen, we're seeing as well. And the main thing that's really kind of driving me right now is the concern we're less positioned to take care of patients if we do see another huge surge of patients coming to our hospitals for care. We just know there aren't as many staff beds as we saw even at the beginning of the summer.
Great, thank you. So y'all have communicated very effectively that we just got through a horribly impactful time on our healthcare system, especially our hospitals. And truly, there was a point, I really was at the point that if it gets any worse than this, we just won't be able to make it, based on how we're used to taking care of folks. And that's right when things started getting better. But a lot of people don't realize we had a lot of federal assistance helping us, get through that, not only with staffing, but field hospitals and monoclonal antibody support teams. And now even, we still have a lot of federal volunteers that are helping us get vaccinations in the clinics, which are very, very helpful. But, I'm listening to those concerns of your employees, and that's a big reason why we're here is, to give the best medical evidence to answer those concerns. And, I've spoken to a lot of different groups all over the state, and I hear the same concerns over and over. And these concerns, are valid. These aren't people trying to make up a reason not to take it. These are people who were afraid to take it for whatever reason. So let's pivot now and talk about safety and efficacy of the vaccines, because the best way to protect our hospitals is just what y'all have said, and that's use our primary tool of vaccination, so that we're not even having to go to monoclonals as much. And certainly through the Delta wave, y'all were seeing what every other hospital was seeing. You were taking care of primarily unvaccinated individuals through the worst of it. And they were certainly the sickest, and the vast majority of people dying were those who were unvaccinated. And we don't want to go through that again. So let me turn to my friend, Dr. Justin Turner. And Dr. Turner, you've had a lot of experience in your private practice, really working hard to vaccinate your community. And tell me what your experience has been and what insight you have for those listening regarding vaccination.
Okay, thank you. I'm Justin Turner. Yeah, so I'm Justin Turner, internal medicine here at Turner Care Clinic in South Jackson, also on the COVID task force with the city of Jackson, as well as the Mississippi Station. And I'm with you all. Definitely agree with everything that's been stated already regarding the challenges. My angle, being out here in primary care, is trying to serve as a line of defense before that patient, gets to the hospital or get to the hospital and even, succumb to death. And it's been interesting. We found out that COVID was here. There was a lot of fear, a lot of anxiety. There was a lot of questionings, as far as where it came from, what are we going to do? And, everybody kind of came together. We saw, not just nationally and federal as far as assistance, but we had with other countries and everyone was working hard. And we came up with a vaccine and it was available. And then everybody was like, whoa, they came up with it kind of fast. Or, let's kind of, I'm not going to say that I'm anti-vaccine, but let me just kind of let the dust kind of settle first. And we did all that praying, for something to happen. We got a surge of, a hesitancy, a lot of people, patients in the medical field. I was just direct that I got from someone that follows me on some message me last week, and I hadn't heard from her, in several months, but she was like, hey, I appreciate your post because your post convinced me to get vaccinated. Here's someone that's in the healthcare field, there's a nurse, and she was really, on the fence and didn't think that she was gonna, follow through with it. And it made me think about something we hadn't talked about before, and that's how much people don't realize the importance of having a primary care physician and also having someone that they have an established relationship with that they trust. It also brought up how many people actually don't even have a primary care provider. When we think about a population that was affected significantly with COVID, as far as our young people, like Dr. Owen said, patients who may not fit the older than 65 and may not have the heart disease and the diabetes. I think in September we had, about 1,000 people in Mississippi under the age of 40, who died, and the majority of those were vaccinated. So when we think about the fact that these are relatively young people, they're literally probably just kind of going to, primary care places, and they tell me they go to, urgent cares when they need to have, healthcare, and they don't really have a primary care doctor and so on. So the majority of the people who were not vaccinated and agreed to get vaccinated afterward were people that like they had to have a conversation with someone that they trust, whether it was in the office, whether it was a forum like this, it was something that's on TV, then they felt better about their decision. Ms. Russell mentioned the one-on-one conversations there. I really feel a good portion of Mississippians are not, a lot of them, they just did not feel as if, or don't feel as if they have all of the information readily, or even feel as if the information that they heard is information that they can trust. So they're kind of like, I don't know, so like Mr. Higginbotham said, they're kind of waiting maybe a couple of years to kind of see what happens, so I've had asked some patients, hey, how long are you going to wait to see? And I said, the problem with that is the vaccine, we are confident that there's no major long-term side effects where the benefit will outweigh the risk. However, we know definitively what the virus does. And we've seen what virus does. We've seen it disproportionately cause patients to more likely have severe disease, be hospitalized, and to die from it. So are you willing to take risk and wait several months while you're waiting to see a TV commercial that shows, if you had this? Are you willing to take the risk and say, hey, you know what? I'm not going to get vaccinated. I think I'm just going to, take my vitamins and I'm going to work on my natural immunity, but not realize that in a couple of weeks, you're going to go home with your family for the Christmas holidays, and you may pass it on to your mom, your grandma, your aunt, your spouse, and you may make it, but what if they don't make it? Are you willing to wake up every day for the rest of your life knowing that you could have taken a vaccine that could have minimized the chance of you getting it and minimized the chance of you be spreading it? And they say, no, doctor, I hadn't thought about it like that. So I say, well, think about it like that. Because that's the reality. So the virus don't care if you black, white, it doesn't care if you Democrat, Republican. Cut out all the outside chatter and just put yourself in this position, not just for yourself, but everybody around you that you love. And love is a selfless act. So with that being said, a lot of those patients, have agreed to be vaccinated. So here in our clinic, we're blessed to have about 4,000 patients, and the majority of our patients are vaccinated. And we have patients from all backgrounds. Now we do have a huge proportion of our patients who are socioeconomically disadvantaged, but we also have a huge population that are African American. So initially, Dr. Edney, the data showed here in Mississippi, over 70% of the deaths from COVID were due to African Americans. Over 6% of the cases were due to African Americans. So as we, worked on a coalition to try to get together, thankfully with the leadership of our state, Governor Reeves, Dr. Dobbs, Mississippi State Medical Association, we were able to, optimize our resources. We were able to get the pastors involved with the churches because people need to hear things from people that they trust. So we got with, so many different leaders across the state, and the data now shows that the percentage of deaths of people who, are dying from COVID, as it relates to the ethnic breakdown in the Black community, is now around less than 40%, which is more consistent with the percentage of African Americans in our state. So, it goes to show that, with adequate information, adequate access, adequate resources, we can really eliminate these health disparities, and we can do what's best to make sure that, everyone has that. But we don't want to just do that for the Black community. We want to do that for every community because we're Mississippians. And the forces that oppose us are never greater than the forces that unite us, all right? So everybody's concern is legitimate. So if I had, one big thing to say, and it's been echoed already, whether it's an employee, whether it's a nurse, because I have those patients, the main thing is making sure that, no one feels like, their concerns are not valid, all right? So.
Absolutely. If someone is asking a question, that's an important question. And we want to be able to give them the information they need to satisfy that question. Dr. Camp Rogers, why don't you speak to the safety of vaccines and what you have learned as we have been vaccinating aggressively since January. We started end of last November, so we've been vaccinating a year aggressively since January. And y'all have been vaccinating a lot of people in Jones County. What is your understanding of safety?
My understanding of safety is that the vaccine is safe, and all evidence, every piece of evidence that's come out suggests that and proves that to be true. I want to connect your question to what Justin was talking about. When we talk to people, I have found that when I am having that conversation with people, it's really important to do exactly what you had pointed out, Justin, is answer those questions about safety, right? Because they are connected to people's fears and concerns, and that's where the hurdles are. And so really taking time to meet people where they're at and asking them to be specific about those fears of safety, right? And asking them in a way, right? Like putting everything aside and having that one-on-one time with them. Because if you can convince one person, it's often, there's a ripple effect. I've noticed between 5 and 10 more people will get vaccinated if one will. So there's an R naught for vaccination. But you can, giving people time and space to say, well, I'm worried about fertility, right? And you say, that's a great question. Let's explore that. Right. And then there's data, I promise there's an article, there's a series of there's a set of robust data for every specific scientific question that people have concerns about, proving the safety of the vaccine. So with fertility, knowing where that is and showing them how you can find that and showing the confidence that we have as physicians and scientists in that data. Myocarditis has been another specific concern that some people have brought up. And going to the original data and using that to guide, people's decisions. I think the question of blood clots related to the Johnson & Johnson, again, going directly to the data and really empowering people to see that, to see where that is and see that the vaccines are safe. So just kind of, addressing people's concerns and showing that the data is so robust, and it proves safety again and again, because if you let people leave it as this vague, I'm worried about the safety, right? If you don't peel that open and explore each topic, then that'll remain a hurdle. And when those conversations happen, I think it's really important, again, Justin, like you had pointed out, to have that conversation with compassion, right? And a non-judgmental approach.
Non-judgmental, absolutely. So we have given hundreds of millions of doses of vaccine in the United States. We have given literally billions of doses worldwide. So as you said, we have robust data. We have no lack of data in terms of safety and efficacy. But we've had two important questions raised let's hit those, actually three. Let's hit those head on, and then we're going to be taking at the last segment of our panel today will be answering questions that are coming in for us. But Dr. Owens, very importantly, infertility continues to be a concern despite the data that we've had. Can you address what the fertility rates, what happens to the fertility of men and women with or without vaccination, and what the rates of miscarriage may be between pregnant women who are vaccinated and unvaccinated?
So when we look at overall the data that's been produced as it pertains to the fertility rates or pregnancy, I guess it's easier to go with pregnancy loss rates. So pregnancy loss rates between vaccinated and unvaccinated people. I think the issue of the fact that, first of all, the first trimester is the hardest and most treacherous and the most dangerous trimester in general for any pregnancy. So the baseline rate of pregnancy loss is highest in the first trimester compared with any other trimester in general, just in women in general. When you look at the pregnancy loss rates of those people who are vaccinated compared to those who are unvaccinated, the differences are minimal at best. But the thing that is really significant is if you look at the pregnancy loss rates of those people who get infected with COVID compared with those, then you see a marked increase. And so I think the other piece is that we as a nation have typically had access to extraordinary healthcare and technology. I think that we might sometimes take that for granted. And I think that we might just make the assumption that we, meaning each individual, is ultimately going to be okay. Like when I have conversations with patients about, are you vaccinated? And it's a pregnant lady and she says, no, I'm going to wait until after I have the baby. That's a bit presumptuous in this day and time. I mean, it really is. And I am a person who in general likes to really be optimistic, but by virtue of my job as a high-risk obstetrician, I have to also understand what risks are out there. And I know that there are women who planned on getting vaccinated after they had their baby, and COVID changed all those plans. And they never got an opportunity to do that. And so just recognizing that as these different variants are coming out, we're seeing that the virus that we first got introduced to at the beginning of this pandemic is not the same. And that almost like Forrest Gump's box of chocolates, you don't know what you're going to get. And while it is great to be optimistic, you need to also be realistic and recognize that this is a deadly virus. And for those women who are pregnant, that is an issue. The other thing I wanted to say real quickly, Dr. Edney, as you talked about that, is I neglected to mention that monoclonal antibodies for women who are unvaccinated and who are pregnant, if you test positive, if you have an exposure, if you're a pregnant woman, that moves you to the head of the line. So in the event that you, for whatever reason, because somebody did pop in the chat, that for everybody, their choice not to be vaccinated is not always political or what have you. They may have other valid reasons. I am not arguing that at all. But what I do want to say is that in the event, because my whole goal is that everybody's safe and healthy. So if you do end up testing positive, then please, please, please find a place where you can get monoclonal antibodies as soon as possible, because doing so may definitely save your life and save your baby's life. With respect to infertility, there's been no increase in infertility amongst people who have been vaccinated compared with the general population. But COVID can kill you and you can't reproduce if you're dead. So there's always that as well. So something else just to kind of keep in mind. And I say that because we've become so accustomed to talking about COVID now that I don't think people think that it's really as serious as it is. And we're still losing people every day. So the data is out there. People who have been vaccinated have been sending their information. Reproductive age women such as myself have been submitting our information after our vaccinations. That data has been, there's been one study that's been produced in the New England Journal, and there are a couple of others. The lay public, you don't have to struggle through trying to interpret scientific literature, but know that that stuff's out there and have those conversations with medical people that you trust, because that's our job. We're supposed to kind of help you break it down. So I just think that that's like going back to what Justin says, you don't have to go to medical school in order to read a journal out of the New England Journal of Medicine. You don't have to wander through Facebook or the internet trying to figure out what's good information or bad information. But whatever you come across, take it to somebody who you trust, who at least has a background to be able to speak to you intelligently about what that means and to help interpret it and kind of help you navigate the things that matter the most to you. But as far as the data as it pertains to infertility, that got started by a hypothetical situation that was proposed on the internet, power of the internet. And from there, it has just mushroomed. And I think what it's doing is it's creating a sense of hesitancy or fear within women and within people who are trying to plan their families that is really not founded in anything scientific. And there's no data to support, with all of these vaccines that have been given, no data to support the unrealistic claim that that's actually what happens.
Right. And I can tell you as a proud grandfather, my third grandchild is due in May, and she is being protected by a vaccinated mama. And I'm so proud. It gives me great relief. We had our second one pre-vaccination. So I'm so proud to have one.
Maternal antibodies can be passed on passively from the mom during pregnancy. We've had babies who've been born that have shown evidence of having protective antibodies in those moms who've been vaccinated. And we also know that those same antibodies can be passed through breast milk as well. So, I mean, even if your baby is too young to be vaccinated against COVID, if you are an immunized mom, then you are actually the first line of protection against the virus for your baby and for your family.
Great. All right. The second question that Doug has had to confront, and it's the basis of a lot of the religious exemptions that have been applied for, has to do with the aborted fetal cells, and that being in the vaccine, and people who are pro-life not wanting to have that. Is anyone comfortable taking that one on, or do you want me to do it? Who feels comfortable dealing with the fetal cell line question?
I feel like you, Dr. Edney, would be perfect for that.
Yeah, thank you so much.
You're
I was
welcome.
waiting I was waiting on the reproductive specialist on it.
I was like, I
Right.
kind of felt like that was you kind of saying, oh, and so you want us to talk about that?
Well,
And
it's
I will,
important.
we can tag team on that one together.
Let's do it.
So
So-
you go first, I fill in the blanks. How about that?
That'll work. So the important thing is to understand if you have gotten the shot or you're thinking about getting the shot, there are no fetal cells, period, in the shot. There's a line of fetal cells that dates back to the 1970s before it was prohibited to use aborted embryonic cells for research. That once they had been produced, they have been continued to be cultivated and used throughout medical research. So it's not like this is something strange, but these fetal cell lines literally go back thousands of generations to the 1970s. And most likely, if you've taken any medication, especially chemotherapy or any type of biologic agent for rheumatoid arthritis or other vaccines, you know, the many medications, vaccines, other drugs use the fetal cell lines as part of their research and development. But no, there are no aborted fetal cells in the vaccines. And, you know, and so as, you know, as someone who cares about that issue, I have had no hesitation in myself or my family being vaccinated. As, you know, again, from a religious standpoint, I don't have any conflict understanding how these fetal cells were developed in the 1970s and continue to be used for good for medical research. And again, nothing in the vaccine itself. Michelle, you have this is a point of confusion among a lot of people. You have any
Yeah.
clarifying points?
No, I think that's true. And I think, you know, sometimes if you're buying perfume or something or a hairspray, you might see something that says, you know, no animals were injured or used in the production of this. In the scientific community, especially as it pertains to research, there hasn't always been a lot of transparency historically about where the information or the data has come from. Now we are in an age where information is readily available. And so now we oftentimes will be able to learn of that. But as you said, there are no fetal cells that are involved in the vaccine. As a matter of fact, it's an mRNA vaccine, and that mRNA does not come from aborted fetuses. And
Right.
so, so the other piece is that what is used to immune response doesn't even hang around in our body for any extended period of time. So I think that is all information that's really important. It's about triggering an immune response within us, and that's where all of the real heavy lifting of the vaccine and the benefits of the vaccine come from. There's nothing in the vaccine that gets to a baby or that can attack your body in any way. And so I think that's something else that, you know, I think piggybacks on that, just as far as what's really in it and how it works. And I think that's something that the public really needs to understand, because I think that information has been not necessarily manipulated, but I think it's the way that it's been presented in so many different formats is very easy to get confused about that. But yeah, there's the process of how this was done. And the interesting thing is that the technology was there all along. It was almost as if the technology was sitting there. I always say God gives you what you need before you know you need it. And so the technology for us to be able to create a vaccine much more rapidly was actually there before we knew about COVID. And the good thing was this is one of those times where science was actually ready when the world had a challenge. It wasn't that the world came up with an idea and science had to meet it. We actually had the technology available before we really were pushed globally in the way that we were. And I think that's something else that people need to know and need to hear.
Absolutely. And then Doug, you brought up probably the most common and I think very legitimate concern in terms of long-term complications that, you know, how can we possibly know what it's going to do in 2 years from now? We know that, I mean, we have a year's experience and we know that as of a year, we're doing extremely well in terms of safety and extremely low risk of complications. But any vaccine has potential complications, correct? So how do y'all address? Anybody want to volunteer? How you address the issue of potential long-term complications, and how we as physicians and public health scientists that's not a concern? Go ahead. Okay, Teresa.
Hey, so I am not an expert in this, but I can tell you, like, but that I think that offers me a unique position, because then I can read about it from the perspective of somebody that might be asking the same question, right? And that conversation is something that I've had with several of our employees. So at my hospital, I oversee employee health and the vaccination program. And so we open the door for these conversations for people to reach out and have them. And that was specifically a concern of a number of people, is what about the long-term complications? And as a very simple-minded ER physician, the way that I look at it is that the way that vaccines are made. So if you read the history of vaccines and the way that they're designed to be a one-dose exposure to inspire your body to make an immune response, right? And so I actually went back and looked up how mRNA vaccines work and what makes them stop, right? So all the way down to the stop codon and how long the protein's in your body and how it gets degraded. And so the way that the actual vaccine is designed is to not work, is the mRNA is gone, completely gone from your body. It stops working when the stop codon is reached. And then I think the ribosomes degrade it. Sorry, I get to geek out a little bit. And then the protein is around long enough for your body to have its immune response. And that's been the way that vaccines have been made since the beginning, like Louis Pasteur, like a very long time. And that's how all the other vaccines are made, is a one-dose exposure. And so the risk for long-term, the confidence in the low risk for long-term effects and the almost, the very, very low risk for long-term is based on the entire field of vaccine development. It's a one or two and done in this case, exposure.
So
I don't know if that's the way I would, if that it helps, but that's what helped me understand it and help me explain it to
That's explained very well, because what you're explaining is the risk that is inherent in vaccines, other medications, other injections are with the dosing. And so that's where the risk is. And yes, vaccines can cause vaccine reactions. We know that with every vaccine that exists. But when we see complications from vaccines, we see them with the dosing. We see it within a couple of weeks, up to a month or so. That we have no history of ever a vaccine just suddenly 5 years later, oh, here's a vaccine complication. So if you've been dosed and you're further than a month out and you've had no complications, our expectation is you will have no complications. So very, very well done. All right, so we have a question for our hospital administrators. I don't know if I can get back to it, David, but the gist of it was how there's, federal money is flowing in. We're awash with rescue money. What is being done for your hospitals with all the rescue plans that are coming out of Washington? And what is it that you need?
Doug, are you loaded with money up there?
We'll let you go first and I'll follow you.
Yeah. Well, what would you tell the legislature?
Let me just tell you, I know most of you guys know my very visible CEO, Lee Bond, and he's gotten the message out. Yes, there have been lots of funds that were given, the ARPA funds. Unfortunately, they have not really made it down to the point where it can be used for, I'm sorry, I'm a nurse, I can say this, overinflated salaries that we're seeing right now, the cost of maintaining open beds. we have had gifts from the state. States come down, help with infusion clinics and other things. Unfortunately, it is not helping the bottom line on any hospital in the state of Mississippi. And I know Doug's the expert on this and can get a little bit more in the details, but I do not know of any hospital in this state that is not truly worried about being able to stay open and operational. So Doug, you want to take that one?
Yeah, there's lots of money coming in. I will be the first to tell you that the federal government and state, the MEMA, FEMA nurses were a godsend when they came. But what's happened is we're now competing with the federal government for labor. And we can't keep doing that. They've got a lot deeper pockets than we have. If you're asking me what to do with the money, I would rather see them give it to the hospitals individually and then let the hospitals decide how best to meet the needs. Because what's happening is it's being decided on a federal or state level and saying this is how you can best do it. Maybe in their eyes, that's how it's done. Our eyes may look at it a little bit differently. So give us the money, figure out a fair and equitable way to do it, base it on volume, base it on need. I don't know, find a way. There's an easy way to do it. I'm sure somebody smarter than I can figure it out. But if you give me the money, I'll figure out how best to put it to work to meet our patients' needs. That's what we get paid to do. I'm going to go back to the safety and efficacy of the vaccines. I'll tell you how I'm doing it. Today is the 14th. So on the 29th, give me a call. And if I'm still alive, I want a $20 bet because somebody said we'll all be dead in a year if we take the vaccine. I told them I have a bet. So, on the 20th or 29th, I'll be $20 richer. The other side of it is I told them if we're all dead, why does it matter? You got billions of people across this country, across the world taking this thing all over the country. Do you truly believe that they're all going to die? And the final point I try to make, I say this facetiously, but you got to understand my personality, my discussion with my staff. The other side of it is, and I think the biggest single point we had trying to sell people about the safety is, I think now every one of our physicians at one point, it was like 99% of them had taken it. I said, these are the people you trust with your life. You trust to make a decision for your life, and they're taking it. Do you truly believe that they would put this in their body if they thought it was unsafe? And that's the strongest argument I think you can make. If they've got a physician that they trust and that physician has taken the vaccine, do you truly believe that physician would put something in their body that would not be safe? So back to the money, just send lots of it. We'll be okay.
I hear you.
Okay.
So Doug, that's a very important point, and it's a fairly powerful statistic because nationwide physicians are voluntarily vaccinated at a rate of about 97% nationwide. So if there's going to be a great kill off of those of us vaccinated, you're going to lose up. You'll have 3% of your doctors left. And that came not because of mandates, it became from making thoughtful decisions based on the data, because we were all watching the clinical data. Everybody on this screen had to go to work 2 years ago before there were vaccines, before we had monoclonals, before we had anything, and barely had a mask to wear. And I remember at the beginning of it that knowing that I was at the bedside of COVID patients, knowing that I was at risk, knowing that healthcare providers across the board had a higher mortality rate than the general population, I got my affairs in order and I went to work and I prayed for a vaccine. I knew we needed a vaccine to get through this thing. And I'm like Michelle, God gave us what we needed, gave it miraculously. Gave us an incredibly safe vaccine that's incredibly effective. And I am incredibly grateful. And I remember the end of November, early December, when Pfizer first came out and we had the opportunity as healthcare providers to get it, I had watched the data and I knew it was safe and effective based on the clinical trials. And I knew that we would need more data, and that really those of us who took the shot last December, early January, we were really the guinea pigs. We were really part of the final beta testing when, the couple of 100,000 of us took the vaccine and we all did well and we're all alive and, we're here to, to enjoy Christmas as it comes up, in large part because despite being at the bedside of COVID patients, we were vaccinated and had wonderful protection. So nurses are running nationwide are running about 85%. I know in Mississippi we're lower than that, but the numbers are improving. So great testimony. The vast majority of us are vaccinated based on the clinical evidence. All right, so we have a question about myocarditis, specifically for those on the front lines. So have any healthcare providers seen true myocarditis type issues in vaccinated children in Mississippi, especially in the boys? And that's where the VAERS data did catch, the signal of mild myocarditis in mainly adolescent boys and younger men. And what have we seen in Mississippi? Have we seen any deaths from myocarditis, and have we seen a significant number? Now, Teresa, I know you're ER, so do you know what's coming out of y'all's ER? And Justin, you're doing primary care. Any comments?
So I have not seen any personally. I have not heard about any that have come through our hospital. I did go back to the original data. There's on this particular question, there was a study out of LA of over, I think, almost 2 million people, and there were 40 cases of myocarditis. And in terms of outcomes of those 40 cases, 40 to 50, sorry, if anybody looks it up, I can't remember the exact number, but it was 40 to 50 cases. And in terms of outcomes, that particular diagnosis in that cohort, my understanding is that nobody died. It was self-limited and it resolved. Out of 2 million people, 40 people that got it and nobody died and it resolved, is my understanding.
That's correct.
So that was reassuring to me. I think it was enough data to suggest caution, like the recommendations that are made in the guidelines that are out there. But to answer that specific question, that's my understanding.
Yeah. So, and that's, that's what the data is showing, and it's real. It needs to be understood, and that it's one of those possible complications with the dose. It's not a long-term complication. You don't get myocarditis in 6 months. It happens, acutely. And with the messenger RNA vaccines, mainly Pfizer, because a lot of the younger ages can only get Pfizer, but it's with Moderna as well. It is self-limited, and the American College of Cardiology has said the risk of COVID far outweighs the minimal risk of myocarditis. So they are strongly advocating vaccination, even of the teenagers, both sexes, but it is mostly seen in males. And I know, Michelle, that American College of OBGYN, has made a strong statement in terms of fertility and safety at all stages of pregnancy and breastfeeding. So, you don't have to take our word for it. Look to the national specialty societies and see, what they're saying. Another administrative question: have you had any folks from the state reach out to y'all in terms of the federal money? Are you being asked how to use it or what you need?
I've had Dr. Dobbs ask us some questions. I had a few of the state legislators ask a few questions about it, including Lieutenant Governor Hoseman. They've asked some questions. I know they've worked some with the Mississippi Hospital Association, asking about how some of the money can be used. And I'm pretty certain that they've contacted other hospital administrators.
Okay.
And we always ask for more than than they're willing to give. So that's just the nature of being a hospital administrator.
Yeah, the lieutenant governor has reached out. He's even done site visits. And of course, we all know he was instrumental on helping fund some of the negative pressure rooms that we were just so grateful to have during this last surge of COVID. And as well, our counties are very interested in hearing what the needs are in the community. So we are getting some interest. And once again, I agree with Doug's statement. We would love them to ask how to better utilize money in the future. We did benefit from the MEMA nurses that were sent down, but I can tell you, I know Kim Hoover from the Mississippi Hospital Association is on the call as well. We feel like that money could have been used a little bit more appropriately. And honestly, in a lot of ways, it probably hastened some departures for staff to go travel. That was part of it. It's such great money. Why don't you come travel and I can get a referral bonus? So it in some ways did backfire on us a little bit. If that money would have been given to hospitals to have internal contracts and things, I think we would have had a little bit more lasting success with the monies that were given.
Yeah, and just one other point, they focused heavily on nurses, and we need nurses, but we also need respiratory techs. We needed,
Right.
Across the board, radiology, we need lab, we need environmental services.
Screeners, everybody.
Yeah, just it ended up in clinics. It's just across the board. My thought, again, let the hospitals have the money. I think we have a better idea where it needs to be used in our individual organizations.
Very good. Dr. Turner, this is an important question because this is a common misconception. And I just want to see how you deal with it in your practice. Can you talk about deaths and injuries from COVID vaccinations? There are over 19,000 in the VAERS report now. So what have you been seeing with all those vaccines you're giving out in your clinic?
All right, so I mentioned before that they would have about 4,000 patients and majority vaccinated. We have had 0 deaths secondary to the vaccine in Mississippi. We have, several people, at least a million who, been vaccinated, and I'm not knowledgeable of the Mississippi who have died there to the scene. Now we need to make sure that everyone understands what the VAERS adverse effects report. This is something that's objective. This data does not have utility because it can. But I've seen links say, hey, these are many people that are dying from the vaccine, or many people had heart attacks, strokes, and these are people who, because of the lack of experience in that particular area, they're saying, research, I did my research, but, there's a big disconnect when you have medical background to interpret it. So that data is subjective. So none of my patients have died who've had the vaccine. As far as side effects, most of the patients who've had side effects, they've had the soreness to the arm at the site of the injection. They may have had some fatigue. I had a little drowsiness, day of, but for the most part, that lasted, no more than about 1 to 2 weeks. So I was going to mention earlier, and Dr. Rogers did a good job explaining it. This vaccine is 1 or 2 doses. And when your body gets the vaccine, the components that are in the vaccine are degraded. They're broken down. You within a span of a couple of weeks. Like last day, repeated, like Nexium that you take because it lowers. This is something your body disposes of within a couple of weeks. So for the most part, if you're going to have a side effect, you're going to typically have it, within the first week or so. So we've seen over 10,000 deaths in Mississippi due to COVID. My understanding is we hadn't seen, due to the vaccine.
And yes, and that's correct. What people have to understand when you give out, literally hundreds of millions of doses of anything, there will be coincident events that occur that are not related other than timing. And that's what you're seeing going into the VAERS report. We give, we who are given the vaccine report into the data bank what we see. My clinic has given out over 5,000 doses of vaccine. And I think we've had 2 reportable events that neither of which were life-threatening. we've had people who died within a month of the vaccine, but it was not from the vaccine. It was from other medical complications, and it was just coincident with the vaccine. So that number, the VAERS reporting is extremely important, and we take it very seriously because that's how we found the vaccine-induced thrombotic thrombocytopenia with Johnson & Johnson. It was through the VAERS reporting. That's how we found the myocarditis, was through the VAERS reporting. So the epidemiological scientists use that raw data, looking for signals, and when they see potential signals, they report it to us, so we understand what we're looking at. But you're correct. As of today, we've had no vaccine-related deaths in Mississippi. The vaccine-related reactions have been self-limited, and I know of no life-threatening complications that have occurred in Mississippi, despite us giving over 1.5 million doses so far. Michelle, did you raise your hand? Did you have a comment?
No, I did. I just think that, the reporting system is really important. And just like what I tell my patients is I like Baskin Robbins. If I go to Baskin Robbins and I get an ice cream cone and then I go out and have a car accident, am I going to say that eating my ice cream cone caused my car accident? And that's really kind of how data is being accumulated. And so that's when all of the deaths that are reported in that database are reviewed by the CDC. And so I think, what we need to do as scientists and as healthcare providers and professionals is just to make sure that, like, we need to own what is out there, because that's out there, but what we need to do is explain it so that people understand how that information is gathered and the significance of, or how we determine what is significant versus what's not, because there's a lot of mistrust about how things are being reported and whether or not people are really interested in being transparent. And so I think that's kind of one of those things that we can do better as healthcare professionals, is to take the time and compassionately and clearly just explain that, not in a dismissive or a judgmental or in a judgmental way, but just to say, you know what, you're right. And if you look this up, you're going to see this number of things that are reported. But let me tell you what that reporting really is. And to also kind of level set so that people understand how, in a way that they can relate to, how they can interpret that. Because everybody's not going to get a PhD in any scientific area, virology, immunology, or any of that stuff just by having a conversation with us. And nor should they have to, in order to feel comfortable in understanding information that they are supposed to be using to make good decisions for their own health.
All right, very, very good. We have 10 minutes left. I don't see any other questions in the chat box unless I'm missing it. And I don't know I can't see what's coming in on Facebook, but any other comments as we wrap it up? Let me share this with you, because the issue of people worrying about dying from the vaccine needs to be, addressed. There's a false narrative that more than 99% of people fully recover and do fine with COVID. That's just not true. The mortality rate in Mississippi is 2.2% of all cases. And then the rate of long COVID, which is having long-term complications from COVID, is running about 10%. And yes, they survive and they're in the recovery numbers, but they're never the same again. Their lives never get back to normal, but thankfully they're alive. But when you move up, talking about the unvaccinated, when you move up to age, when you get to age 65, you're talking about a 10% mortality. If you're 50 to 64, you're looking at a 5% mortality. And if you're unvaccinated, when you're vaccinated, as a 60-year-old, my mortality went from 10% down to less than 1%. And that's phenomenal. That's a very impactful improvement. But what is scary is if you're sick enough to get into the hospital, then your mortality rate runs about 14.5%. So, you know, Doug and Susan, all the folks that y'all met with COVID, you know, when you look at all comers, you know, about 14.5% of those folks don't leave. If you're sick enough to get moved to the ICU, it moves to, you're in the 38% range mortality, just by being sick enough that I can't manage you on the floor anymore. And if you're unfortunate enough to require mechanical ventilation, then, you know, 2/3 of those patients don't survive. Vaccination virtually eliminates those risks. So, you know, yes, thankfully, more than 98% of people survive COVID infections and do well. But, you know, there's a lot of people who are sick for a very long time. A lot of people are never the same again. And as Dr. Turner said, more than 10,000 Mississippians are not going to celebrate Christmas this year. And, you know, too many of those were children, and too many of those were pregnant moms leaving COVID orphans behind. So, you know, the take-home message today is that you're looking at a group of healthcare professionals that believe the vaccine is safe and effective. We've taken it, encouraged our families to take it, encouraged our friends to take it. And, you know, we want you to feel safe in making the decision to become vaccinated as a healthcare worker for your safety, but also for the safety of those that you care for. Thanks everybody for taking the time to be here. You know, everybody had a busy schedule today, but those of you who are listening, you're looking at a group of healthcare professionals that care about their communities and are willing to take the time out to have this important discussion. If you still have you know, questions or concerns, we are very happy to take those questions offline and be of help anytime. If you have a healthcare facility that needs someone to speak to you, you know, the health department will be happy to make those arrangements. And y'all, so our panelists, thank y'all so much. Great as always. And if there are no Sharon, Ms. Sims, did you have an issue?
There was one other question that was in the chat.
Okay, what's that?
It is, was there any negative psychological impact noticed on hospital staff working beside contract staff who were working at a higher salary?
Yeah, I thought Ms. Russell hit that pretty well, but what do you think, Ms. Russell?
I wouldn't say it was psychological, but it you know, it's a morale booster whenever you see somebody that comes in that's temp staffing that gets paid more. Most of our individual staff realized we were in a crisis. We didn't have a choice and we needed all the help we could get. At the end of the day, it never feels very good to have people who come in that make more than you do just because you're in a bind. But we're working with our teams, doing everything we can. But once again, this is something that everybody in healthcare is dealing with right now, unfortunately.
Right. Doug, you have any comments?
Ditto.
Ditto. Man, I like that. All right. Well, again, thank y'all so much for being with us, both the attendees and the panelists, and y'all have a great day. Please stay safe through the holidays. Bye-bye.